Go.
Hi, we're here with Mr. Mike Malone at Riverside, and he's one of the physical therapists. So, Mike, what got you interested in physical therapy?
For me, it was talking to the right person at the right time. When I entered college, undergrad, I didn't know exactly what I wanted to do. I thought maybe teaching, something in the service profession. So as I started researching it between my freshman and sophomore year, started talking to more people, somebody said, well, have you thought about physical therapy? And I didn't even know what it was. I'd never been through physical therapy myself. Hadn't really spent any time in physical therapy or talking to therapists. So I started researching it, went to my local hospital in my hometown, talked to the director of rehab there, and he showed me around, let me spend some time with him, saw him treat the patients, and the hour I spent with him was pretty much the deciding factor for me. After that, it was going through the prereqs, school-wise, but also doing volunteer work in different clinics and learning about the profession that way, reading about it, but then also learning about it from those clinicians that I spent time with.
Okay, awesome. So how many years of school then did you go through? Do you have your doctorate?
No, I graduated with a bachelor's in physical therapy, graduated in 1997, which was on the cusp of the transition to a master's program.
Right.
The years after me were master's level. I graduated with a bachelor's, but we did basically an undergrad type program that was 3 years of undergrad, we'll call it in quotes,
right.
Undergrad, because I was a year behind from where I started. I did 4 years of
Okay.
undergrad, got those prerequisites out of the way, applied to physical therapy school, got in, and then our physical therapy program itself was 2.5 years.
Okay.
So it was basically a master's level education that I got credit for a bachelor's.
Right. That's interesting.
Yeah.
Okay, yeah. So you are an inpatient. What's the difference between inpatient and outpatient? What kind of patients would you see an inpatient versus outpatient?
So inpatient means we work here in the hospital. We treat the patients that are in the hospital. So patients come into the hospital with various illnesses, surgeries planned, and the time that they're here in the hospital, that's the time that we would see them. So they might come in for a total knee replacement. They have their surgery. We see them that same day. We start getting them out of bed that same day, start going over their exercise protocol, start going over their mobility, training to use a walker, crutches, device that they're going to be using, prepare them to discharge to home. And that's a lot of what we do on the inpatient side. We might see patients after a stroke, we might see patients after a car crash or an automobile, multiple trauma type event, might see patients after open heart surgery. They might come in with pneumonia, infection. It could be a various, there's really nowhere in the hospital that we don't see patients.
Okay.
From the emergency room all the way to discharge and sometimes even hospice. We might be seeing those patients for a consult as they approach death and are being well supported by the hospice staff. There might be therapy needs in those areas as well.
Okay.
So inpatient is the patients that are in the hospital that need hospital care, physician care, nursing care, and therapy and rehab becomes sort of an adjunct to that. It's not the primary purpose of the reason that they're here.
Okay.
Whereas outpatient, you're going to an outpatient clinic because you need physical therapy, because you need occupational therapy, because you need those services directly. Your physician has likely said, okay, you've torn your ACL, you've had surgery, you're home now, we've got to start going to physical therapy to go through your exercise program, or whatever your injury might be.
All right. So how do you go about creating a plan to get the patient from the hospital to home to, long-term care?
So our initial planning stage begins, with the review of the chart. We're looking at the chart, we're finding out why the patient is here and what they need, why they might need us. So it's that problem solving of why have we been asked to see this patient. So that starts with the first click in the chart, in the electronic chart, and then the decision making process is through the time that we spend with the patient. So we might see the patient, interview them, find out what their prior level of function means, meaning what were they doing before they came to the hospital? Were they able to be up and walking? Were they mobile? Were they active? Were they taking care of their own self-care needs at home? Were they working, taking care of their kids, whatever the situation might be? Then finding out what their current state is. Okay, they've been ill for 2 weeks, they've been in the hospital for 2 weeks. What can we do to help them along here while we're right here in the hospital? And then the decision making of what comes next. What's the next step? Are they going to need outpatient therapy once they leave the hospital? Would we recommend that? Would we recommend a cane or a walker or something to help them with that, or a particular exercise program that's going to help them with those needs? So that plan is very individualized. It very much depends on what the patient needs, what the patient's current status is, and what their goals are for returning home. And part of that plan is that goal planning piece. coming up with, okay, the patient wants to be able to do this, this, and this. They need to be able to do it. I feel like they could do that in the next 5 to 7 days if I have a chance to work with them.
Okay.
Or they're going to need further care, and we'll send them to an outpatient clinic, or we'll send them to a skilled nursing facility where they can work on those things with those therapists.
Sounds like a lot.
So did that kind of answer the question? In
Yeah,
terms of how we
absolutely.
plan? Okay.
We're just kind of wondering, just everything. So what's something that you just really enjoy about physical therapy and, working with the patients?
Yeah, it's exactly that. It's that time with the patient that you have one-on-one interaction, to be able to spend time with them. Oftentimes in the hospital, we're the first ones seeing that patient after their surgery, after their injury. I think that's one of the reasons I like this setting. I like being in the hospital, and especially a big hospital like this. Sometimes we see those worst-case scenarios. It might be a severe trauma accident, it might be a life-altering stroke, or even just a knee or hip surgery that's changed their life and changed their function. We're the first ones to get in there and have our hands on them to help them with these things. They might go to outpatient therapy, they might go to skilled nursing after this, but we're really the first ones that are dealing with their life-changing events, whatever those are, and starting to educate them, teach them, and start to see the improvements in them. So that's my favorite part.
Yeah, sounds awesome.
So in that one-on-one interaction with folks, you get to learn so much about other people. You get to learn so much about the way other people live, the way other people view their lives, what their goals are. Sometimes very different than what mine would be.
Right.
But what my goals are for that patient don't always matter. If something's very, very important to them to get back to, okay, that's what we're going to work on.
That's awesome. Yeah. So then, what are some of the disadvantages?
Yeah, I mean, the hard parts are, being in a big hospital like this, sometimes we get swallowed up. We're a relatively large department, in the biggest hospital in the city, which is great. Yet, when you're talking about being in the hospital, you've got the doctors and nursing care, all the tests that they might run, so they might be going to x-ray or this CAT scan. They might be going down for a particular procedure with the physicians. You might have the lab folks coming up to draw their blood. All those interruptions, therapy, whether physical therapy, occupational therapy, speech therapy, those things become secondary, or sometimes even tertiary. They're kind of down on the totem pole of importance for what that patient needs right now. So sometimes that you feel that way, even though I feel like I'm providing very, very important service to the patient. Our role here in the hospital is in that discharge planning and that recommendations, that what comes next step. And so it's not always in the hands-on follow-up. I'm going to see you tomorrow and the next day and the next day and make sure that you're achieving these goals. It's we'll get back to you as soon as we can because we know you need us. But the doctors are going to discharge you from the hospital when you're ready to leave the hospital, not because you're done with therapy.
Right.
So those are frustrations, in the hospital setting. But those types of things can also be exciting because it's constantly new people.
Yeah.
It's not the same patient day after day after day after day. Okay. New people, new faces, new adventures.
Sounds exciting.
I think so. But those frustrations, then there's the paperwork and the documentation, all those types of things, which, the requirements keep growing and growing and growing in this day and age, that we need to, continue to, while those are big time killers for us to spend time doing that, we have to do that to fulfill all the requirements necessary, and hopefully still see as many patients as we can and help where we can.
So is there a lot of paperwork then?
There's a lot of paperwork.
Right. Okay.
For any medical professional,
right.
There's a huge paper trail. That's not paper anymore. It's all electronic, but it's there are a lot of requirements, and that's a big part of what we do each day is document what we do, fulfill those requirements, and make sure that all the powers that be are happy. I's are dotted and T's are crossed.
Right.
Keep the lawyers on it.
Exactly. So then, our last question is, how do you really feel about how the profession of physical therapy is headed, and such education-wise?
Yeah, I think it's great. I think the ability to move along, like I said, I was trained as a bachelor's level. I think that the ability to move into a master's level requirement now with the doctor of the DPT programs, students are coming out with a little bit different. I mean, they're a little bit older by the time they graduate. There's a little bit more maturity. There's a little bit more life that they've lived. I think so from a professional standpoint, just a professionalism standpoint, I think the students are a little bit better prepared for life in general, coming out, with that level. And I think that it certainly pushes the profession forward in the eyes of others when you can talk about having doctorate-trained clinicians and therapists and experts in those fields, working with you, working alongside those patients. It certainly helps to bring some like I said, in this environment, we sometimes get lost in the shuffle. It brings some cachet to the forefront of how we're trained and showing that it is a highly trained and highly skilled service that we're providing. So I think it's great the way the profession's going. Obviously, the aging population, so the population's getting older, living longer, needing more services like ours, whether it's inpatient, outpatient, or home health services, whatever. We need more therapists out there. And I think it's going to continue to grow because of that support, but it's also going to continue to grow because of the professional backing that we have now.
Well, that's exciting to hear. Well, thank you very much. That's all I've got for
You're
you
welcome.
today.
Sure.